Okay, hold in there, everyone. We're almost to reception time. This is our last session, and an appropriate one because now we're going to look at the big policy issues and translation of knowledge from research to practice and all the way up to government policies. Three presenters are on this panel. The first is Leslie Gaudette, who's president of COSCO, the Council of Senior Citizens Organizations of BC. A second speaker, I'm going to introduce them all at once now so we can segue right through. The second speaker is Kahir Laji, Provincial Director, Government Relations and Government Programs of United Way, British Columbia. And the third speaker will be Isabel Mackenzie, Seniors Advocate of the province of BC. These are three major organizations in British Columbia, so we're going to really bring things, focus them into this province. So without any ado, Leslie, will you come up? And we'll follow with some nice Q&A.
Okay, well, thank you, Andrew, for that wonderful introduction and for inviting me to speak to this group. It's truly an honor. I graduated from Simon Fraser many years ago with biochemistry degree, and here I am on social planning or whatever. So it's quite the change, and it's also interesting to be the last group in the afternoon with pressures of time and trying to keep everybody awake before the reception occurs. But I'm really pleased to have such excellent co-panelists with me on this group today. So looking at COSCO, we're looking at things using a senior's lens. Our goal is to plan with seniors, not for them. So involving seniors in policy development is really key. We've been representing seniors in BC since 1950. Next slide, so I press that. Okay, so a lot of, the other thing about talking last is that half of what you said has already been said. So I'm just gonna go quickly through. We're going to talk a little bit about how healthy aging. We're gonna talk about COSCO. What is knowledge translation? Most of you know, and we've seen lots of examples today, but I'm gonna delve a little bit into an example of social housing. We want healthy life expectancy, and I thank Judith that's better than quality adjusted life expectancy, but we want to age in the right place, which you'll hear about tomorrow, supported by age-friendly communities. You can't live independently in your own home without a community around you as you age. The key elements of healthy aging, and Judith went through these, there's income, housing, healthcare services and benefits, transportation, and the built environments have been wonderfully described in earlier presentations today. Nutrition is really important. Never underestimate, as my son when he was at university said, the power of free food. And that will bring seniors together too. The next group is more social in nature, and we need social inclusion. I think in BC and in our multicultural society, it's really important to value and respect cultural differences and diversity and try and learn how we can all be together. There are so many issues that are the same across cultures, but we don't always get together to discuss them. And we need safe environments free from ageism and elder abuse. So about COSCO. Our purpose is to assemble, coordinate, and advance proposals and resolutions concerned with the welfare of elder citizens and submit to government. We also, through education, advance the social and physical welfare of all elder citizens in the province of BC. We see as a clear voice for all older persons, especially for those with low incomes. And as Isabel will probably tell you, half the seniors in BC are living between $20,000 and $30,000 a year, and about a quarter are around the $20,000 level. So there's not a lot of money even to participate in something like this. Our membership involves 70 affiliated organizations representing 80,000 seniors. We're an umbrella organization. We have affiliate groups located in all parts of the province. We have 4 major groups: the BC Retired Teachers Association, the BC Retired Government Employees, the BC Forum, which is of retired union members, and the BC Old Age Pensioners Organization, which has been around. It's the longest serving organization. It's been around since 1932. They celebrated their 90th anniversary. A lot of these groups formed in response to the need to put pressure on government for better pensions. We also have a number of senior centers and planning tables, some of which are faith-based or ethnocultural, and we have a number of union and retiree groups who are interested not only in protecting their own pensions, but those of generations to come. We have a number of individual members who appreciate getting information more quickly than they might get otherwise. We are volunteer-driven, and we are independently funded through member dues, donations, and occasional grants. The real strength of Costco, as I learned when I became president, is the number of the network of affiliations and partnerships, because this is only some of them. There's probably another list equally as long I could put up. And I found that working with partners has been very effective in getting issues brought forward. Our key advocacy issues align with healthy aging, and I didn't realize that fully till I did this presentation, so I learned something. Thank you, Andrew, for that. And I'm going to just skip over the current issues because I wanted to just briefly touch on knowledge transfer. So knowledge translation is defined as dynamic and iterative process that includes synthesis, dissemination, exchange, and ethically sound application of knowledge. And this is aimed at the health of Canadians because it was developed by the Canadian Institutes of Health Research. And I realized that a lot of the work I did when I worked for the federal government for Health Canada was in knowledge translation. So you go through the steps, and many of the presentations today have illustrated this, but you get your questions, you conduct research, you publish findings in plain language so that normal people can understand it, and you don't have to be working through academic language, which I've spent quite a bit of my time doing. You place the findings in context, which we've seen a lot of good examples, and then you make decisions and take action. This is called evidence-based. And you use the results to influence subsequent research, and we've seen a lot of examples of that, so I didn't have to have the fancy diagram. So this is the simple planning framework. What is the info? What message do you want to convey? For whom? Who's your target audience? By whom? Who's the messenger? How? Well, we've talked about knowledge transfer. And with what effect? Evaluation. So I'm going to give an example of a housing policy development using a social housing example. This is a housing complex in Langley, which is my hometown, that's been described as a poverty ghetto. It's a fairly large one for the province. There's approximately 600 tenants living there. So the early information happened I see there's a little timer here. I can keep track of my own time. There's good tech. Anyways, there's the early warning. Then 2 tenants came to a Langley Seniors Community Action meeting reporting on unsafe living conditions. And this is, of course, a group that was initially funded by United Way. We spent a lot of time investigating and meeting with Fraser Health and trying to figure out what was going on. There was people with disabilities being housed there with mental health and acquired brain injury. We then spent, and I won't bore you with all the steps we took, but there was literally dozens of meetings over the next 2 years. A really key thing we did was we got $2,500 to fund a focus group meeting through the BC Poverty Reduction Strategy, and this also involved 40 tenants filling out a form, and it was really a very rich source of information. And we did submit a report and worked over the summer to build a report, which is actually on the United Way core research. And we met with Isabel to get her involved. And we found that tenants were very low income and in poor health. They are socially isolated, but they had lots of great ideas for improving their built environment in particular. And the core problem we identified was the mixed tenancy. Having all these different groups together did not work very well without greater oversight. So we developed resolutions through Costco and the National Pensioners Federation and learned that we were not alone. There are many other complexes like this across Canada with similar problems, but really nobody, as we learned, really wanted to talk about them. We did present results to the Fraser Health. We met with key members of Fraser Health Management. We wanted to try and work with the housing provider and local community groups to try and improve the services available on site, but it was very hard to get any inroads whatsoever. We continued to meet, and then in the fall of 2019 at the United Way Summit, we met Josh Cook, who was an SFU master's student. You see all the connections that are occurring. And his thesis came out in 2020, just as COVID hit. And one of his key recommendations was that there be tenant support workers in these complexes, and I would term them resident services coordinators, to help connect these very poor, very low-income people with the services they need. And I think there's also a need that, as Joss pointed out, to have research to determine why some complexes have issues and others don't. And that's an unmet research need at the So this is just, and it's lovely to have such a big screen that you can actually read at the back of the room, but these were a number of issues that we had brought forward in the report, and I just thought for fun how many have been acted on 5 years later. So we have seen the government trying to improve the number of social housing units dedicated to seniors. I'm not sure there's been that much improvement. There's a greater awareness at the highest levels of government in terms of housing these mixed groups that aren't that compatible. Safer subsidies. This is a rental support shelter for elderly renters. And it's supposed to be improving, but it constantly needs adjustment, which we're trying to get the government to do something about. We're trying to get the senior supplement increased even further because we're behind those of other provinces, as Isabel's pointed out. There's extended healthcare benefits to all seniors, and Isabel has pointed out BC seniors are falling behind. And then we need community navigators in senior centers. This comes out time and time again in the work we've done in Langley, so that it's easy to navigate processes for seniors needing to access all the programs. I think we've got now some supportive housing in place that is taking the pressure off the seniors housing, and this is supportive housing for persons with mental health and substance use. And the government is working on funding additional treatment facilities for persons with mental health and substance use, which is helping a lot. So thinking of knowledge transfer, was the message clear for this large, messy problem? I'm not sure. There were many target audiences due to many players, and this included government and government-funded agencies. Who's the best messenger? Well, you have to be prepared to get shot when you bring stuff like this up. I'm sorry to say, but it was quite amazing being in meetings, and your voice, they just didn't want to listen, even how nice you were. So there has been some changes as a result, but there's an ongoing shortage of housing that exacerbates the issue. I think there's a lot more research that could be helpful to identify best practices in BC nonprofit senior social housing. So involving adults or older adults in research, it's important to capture the lived experience from ages 55 to 105. We need sustained core funding for senior centers and planning tables. These are the community incubators that identify problems and devise solutions. We need to involve groups representing seniors at the beginning, and I congratulate Dr. Wister's team and the SHIRT grant application involving seniors groups right from the get-go. We do have in Costco members with diverse backgrounds to provide input. Oh, I think I went the wrong way. So I'm going to skip that But this is the Canadian Coalition of Aging, and when Kahir and Isabel and I were all in the same room, and I've used up too much time, but I'm going to stop now. Thank you very much.
Thanks, Leslie. Doing a sound check at the back there. I'm debating whether to use a PowerPoint or not. I think we're probably PowerPointed out, so I'll just have a bit of a conversation with everyone here. So I'm with the United Way, British Columbia. One of our flagship programs is Healthy Aging, United Way. And I wanted just to start off by, first of all, extending my congratulations to the GRC for 4 decades of impact, research, and education. I spent many of my years here, so congratulations on their 40th anniversary. But I wanted to start off by just saying there's 3 areas over the last probably 2 to 3 years that we're seeing increasing trends in. One is a need to better integrate home and community care programs and services. The next, and we'll look at isolation and loneliness as a rationale to invest in upstream preventative community-based programs. And 3, the impact of climate injustice, I would say, which disproportionately impacts older people in communities across the province. I'll start off, though, with maybe presenting a bit of an issue, and which is probably a bit of a healthy tension. And there's a need, as we all know, to support responsive and reactive acute healthcare needs. But there's also a need to look at investing in upstream preventative programming. And you can imagine a tension here as they both require resources, both people, talent, and financial resources. And so this kind of lays the foundation of some of the conversation that I'm hoping to engage in here today, but really kind of looking at the difference between downstream reactive investments, reacting to problems, the treatment of illness and injury, versus upstream, or not versus, but and upstream preventative program, which really looks at promoting healthy environments, preventing injury and illness, but also looks at social inequities. Over the course of the last couple of years, we've been working with about 240 community-based senior serving organizations across the province. And we often found, while speaking with both organizations, as well as those in the primary care field, that there is a gap in conversation, and there is a gap in the continuity of the provision of services for older people. Often we find when somebody has some type of health-related issue, they'll go to their family doctor. If there's no family doctor, they might make a visit to the emergency room. What we also know, though, is less than 5% of referrals to community-based programs come from the healthcare field, from doctors, from emergency rooms. So there is a problem and a gap in the provision of integrated services and programs. There's one lady I had the pleasure of having coffee with in one part of the province. She had been into the local community's hospital 6 times in a period of 7 months. And she was being treated for the physical symptoms that she was exhibiting. What we found out was the solution was a $50 fix to her window at home, which was not closing during the middle of winter. If we take the time to get to know people, if we're able to build a place of trust and relationship, and if there's adequate referrals and an adequate system of support, some of these challenges could be avoided, could be prevented. And so when we are evaluating some of the programs that we provide, we kind of try and take a critical lens on what's happening. And the recommendations from all of our formal programmatic evaluations was to strengthen and enhance the relationship between the community-based nonprofit sector and the healthcare system and the health authorities. It's a tricky situation. The demand is high. Resources are scarce. But it's a tension that I think that we need to address. It's complicated, but from my perspective, if we talk to the experts, older people, their family, their friends, and their caregivers, the sense is we need to find a balance. The second public policy area I want to quickly talk about is upstream preventative programming. We know that the feelings of loneliness and subjective isolation can lead to things like mortality, cardiovascular disease, etc. We also know that people live where they want to live, and there's a desire for people to live at home when it's right and safe for them to do so. And so United Way has worked with government to create a suite of community-based programs aimed to support older people to be connected, active, and engaged in their communities. We operate under the philosophy that vital connections are instrumental to one's quality of life. So being able to curate, facilitate, offer programs and services at a hyper community level allows people to be engaged and connected with their neighbors and also be part of the provision of programs and services. 2/3 of the volunteers that provide programs and services are over the age of 65. But there's a caveat I want to add here, and that is everybody experiences life differently. And I think we need to look at that and take a person-centered approach to how we're looking at developing public policy. For example, we're getting ready to welcome newcomers from Central Asia, from Middle East, many of which are older, but come from places of the world whose lifespan are very different than the lifespan in their new home countries. And that is then exacerbated by navigational challenge, linguistic, cultural challenges, and so paying attention to the diversity and the ethnic composition of the people that we're supporting is fundamentally important to inform public policy. There's health equity issues in terms of accessing programs and services. And programs like social prescribing, which some of you in this room may have heard about, helps to address the health equity piece, to allow programs and services and wellness plans for older people that are relevant to that person based on their individual experiences. The third area I would quickly talk about is climate injustice. So we know that older adult populations typically experience the most casualties or are disproportionately impacted by fires, by floods, by power outages, as well as by human-made disasters. And we saw this with the number of displaced older people that we welcomed in British Columbia, which had multiple generational challenges that had to be navigated. We also have seen in local community evacuation plans, for example, where policies, quite frankly, are ableist and ageist and need to be addressed so that older people are considered in climate vulnerability and, I would say, injustices that have been served to older people during climate and human-made disasters. And we saw this in the heat dome. We've seen that in evacuation plans for seniors in areas where under evacuation alert, whether that's through floods or whether that's through fires, etc. I remember we were on site at the flooding in Abbotsford, and there were a group of older people who had received some cash from partner organizations. But they came to us and said, like, well, what do we do? We need to get groceries, but we can't get to the grocery store. Like, where are we going to go and cook all our food? So we need to take a person-centered approach, and we need to critically look at the policies in place for emergency response and preparedness. So how does this kind of translate to knowledge translation? I would offer three suggestions. One, in the development of public policy, it's instrumental to hear the voices of community. To actually going into community, one of the beautiful things about our province is our geography. It's also one of our challenges of our province around accessibility. And so actually going and spending time with people that live in rural, remote areas of the province, going in and visiting people that, have, I would say, are the experts in what they feel they need to live in safely in their homes, but really amplifying the voice of community. Second is to demonstrate impact. And so, we've been innovative in, for example, looking at social prescribing. Some of you have heard of the Better at Home program. These programs are not without their challenges, but they need to evolve, and we need to demonstrate impact. And so one of the things that we do is we work with government to take a number of community-based organizations through a year-long developmental evaluation of their program, which culminates annually into a book of evaluated programs that prove and improve the work that they're doing to support older people, which helps to articulate and demonstrate impact. The third, I would say, is to engage in public discourse. So through things like regional consultations, through our Summit on Aging, as well as through online platforms, engaging in provocative public discourse is important to fuel critical eyes on policy, as well as programs and services that are offered. I'll leave my remarks there and hand it over to Isabel.
Okay, thank you. I'm just going to put a timer on here. There we go. Okay. Thank you very much. And I would be remiss if I didn't add my congratulations to Simon Fraser University on the 40th anniversary of the center. And I thank you very much for inviting me to speak to you in what will be my last Friesen conference as the Seniors Advocate of British Columbia. I've been to many during my tenure, so I am very grateful for this opportunity. And I just want to reflect on the fact that when the center was formed 40 years ago, the oldest baby boomer was 36. And I think that's the age people move out of their parents' house now. But the philosophy then was, what is the one thing people under 40 are not interested in? Answer, people over 40. And so it speaks to, I think, the tenacity of those who formed the geriatric research, gerontological research community back in those days. And of course, we've spoken of our trailblazer, Gloria, and I certainly add my thanks to her efforts and her tenacity and her vision over these many years in building what is a fabulous, fabulous repository of gerontological research and a beacon within the Canadian academic community. And there are many, many things to admire about Gloria, but I think, frankly, the thing I admire most about her is the ability to wear those heels. And I think it's the one thing I will not be able to emulate, but my congratulations to Gloria and to the center. So this has been billed as translating knowledge translation and into public policy. And so I think what is interesting to realize is that if we translated knowledge into public policy, here's what life would look like for seniors in British Columbia. I would be able to call one number, and the person who answers that phone would be able to connect me with getting my medications delivered to my house, would be able to materialize for me somebody who could come in and help me when I needed some help. When I got discharged from the hospital, I would know that I would be going home to a refrigerator that had a quart of milk and a counter with a fresh loaf of bread, that the equipment would be there that I would need to support me for my recovery and convalescence. I wouldn't be worried about having enough money to meet my basic needs. I would have confidence to know I can pay the bills, I can get the medication, and I can have the help I need in order to stay in my own home. And we know that that is actually not what it looks like for seniors in British Columbia and arguably in most provinces in Canada and in many countries around the world. And so the question is why? Because we do have the knowledge. We know what needs to be done. There's innovation around technologies, there's better ways of doing some things, but the basic day-to-day functions that we have as humans have not fundamentally changed in thousands of years. We have to get up, we have to get dressed, we have to eat. We have to have a purpose. We have to have people we can talk to. We have to have something on the calendar. We have to have hope. We have to have a reason to keep going. And then, as our body starts to meet some challenges, there's people who come in and help us. That hasn't changed, and it doesn't look different wherever you live in the world. So we know what we need to do. Why are we not able to translate that into the public policy that would then translate into the services that are delivered to people? That is one of the questions we have to ask. And I think one of the reasons we don't ask it is we might be quite uncomfortable with the answer. And some of you are going to be uncomfortable with the answer, because part of the reason we have difficulty translating knowledge into public policy is because of the many, many stakeholders, service providers, businesses, all of whom have a better mousetrap to sell to government, older people, name the list. And what's missing in all of this is who are we actually serving, and what is their role in all of this? And it's complicated because in the natural marketplace, you would develop a product and you would sell it to a consumer. And the laws of economics would sort everything out. Good products would sell, bad products wouldn't sell. Innovation would be required because you need to keep building the better product because the consumer is going to want better, higher, stronger, faster. It gets complicated because there's not that direct relationship. There's government. Government is buying and then providing. And it was interesting to hear about when we heard what was happening in China, in Singapore, mentioned Sweden, I've been to Denmark, all countries, high government involvement. My friend Judith from the UK, not so much government involvement, a lot of talk about the need to get the private sector to innovate and what it is. We look at Singapore, where 80% of the housing is for the citizens, that's owned by the government, is for the citizens of Singapore. Interesting to note, the people providing the care aren't the citizens of Singapore. And so it's a very, very complicated thing. But the problem is we won't talk about these real issues. Why? Look to your governments. Government is the people. We are the government at the end of the day. And when you get into the room, it suddenly becomes like high school basketball and everybody has to play. And that creates a problem. Because in our ability, if you think about how does innovation work, what's the natural discipline of the marketplace? Competition and choice. And we don't really have that because the person, the consumer, isn't making that choice. We're running around trying to outdo each other with this newest little thing, this nuance of a program, this group over here that says, well, we deliver this specific little niche service to this group of people, and then this organization delivers this little niche service to this little group of people. And they all have very, very compelling stories. But then when you get down to the senior, they just want the service. And so, I was struck by, this was about 4 or 5 years ago, and it was over on the North Shore, and they were extremely proud of this project because they had managed to develop a list of the 7 numbers you need to call. That was their pride point. It was only 7 numbers. That's 6 numbers too many, right? When we think about the fact that most of us go through life able-bodied, most of us don't live and breathe the world of gerontology or the world of healthcare or the world of government bureaucracy. But when we suddenly find ourselves in that crisis moment, which is usually in the emergency department of a hospital, suddenly we come face to face with this wall called the bureaucracy of healthcare, government, service providers, whatever you want to call it. And there's nobody there with the clarity and the mission and the mandate to take us through it. Why? We get all complicated. We don't want to recommend, your loved one dies in the hospital. When your loved one dies in the hospital, we just tell you you have to phone a funeral home. We don't tell you about, well, you know, there's simply cremations at $1,700 or Sands Funeral Home at $6,000 and you don't really have, we don't tell you any of that. We just let you, when we discharge you from the hospital, we might give you home support, and then we'll tell you, well, you can always, you know, get private care if you want, and the equipment will give you the requisition to take down to the Red Cross cupboard. We do, and so we're left adrift, and what happens is, inevitably, all roads lead generally to the long-term care home. And who gets lost in all of this the most, not exclusively, but the most, which both Leslie and Kahir have spoken about, is those who are more socioeconomically disadvantaged, either by language barrier, cultural barrier, money barrier, lack of sophistication, of understanding how to work their way through that. And nowhere is the evidence of this greater than when you look at who's in care homes, and we know their socioeconomic status because we know how much money they make because we take 80% of it, and we see who's not. Why? What's the difference? The difference is the people, generally speaking, with resources, not exclusively, also have all the tools to figure everything out. And so they don't need our help. But the people who need our help, we're not there. And I think we need to think about who are we really here to serve? And when we think about that, as government, we've got to understand our role. The role of government can't innovate. We can't manage. We're very bad at that. Our role is to regulate and allocate. And we have to understand and come to grips with that and be prepared to have the adult, tough conversations that need to be had, such as my alarm is having with me right now, telling me my time is up. So with that, yeah, I've had the tough conversation with my timer here, but I will leave on that note. We need to think about who is it we are really here to serve, because that does get lost sometimes in the room of all of us talking about what we're doing for the people. We have to remember who we're doing it for and what it really means. So on that note, I'll leave.
Let's give a round of applause, please. Thank you, Isabel, Leslie, Kahir. We have time for some questions. We have about 12 minutes. We're going to stay on time. So if we could ask any people with questions to come forward. There are a few.
Hello, Anne Martin Matthews from the University of British Columbia, and thank you so much, not just for your presentations today, but for what you do. You are at the coalface of the issues that Isabel's been talking, you've all talked about, and so I want to thank you for your work, your advocacy. I think some of what we've just heard represents in some ways a sense of this is what we're doing, but there's a call to arms here. And I'd have to say, as I approach the end of a 45-and-a-half-year career, knew Gloria back in the day, right, Gloria? A career in aging, one of my tremendous frustrations was last week reading Andre Picard's op-ed in the Globe and Mail when he was talking about British Columbia sending cancer patients across the border. But there's a line in here that I think is a cautionary tale for those of us who have for 40-plus years worked in this area. And you're speaking to some of this. At some point, he says, we have to stop pretending that the aging of the population and the shift in care that needs to accompany it are a surprise. We have to be aggressively proactive, not pitifully reactive. And then he goes on to say, of course, cancer, we know cancer rises prevalence with age. We've known for years this was going to be an issue. But that core message in his commentary, you sit there, what can we do differently? Have we not been doing it right? I mean, I think there's elements, Isabel, of what you're saying there, remembering who we're talking about, but how would you respond to that? I mean, what answer would you give to a statement like that? We need to be working in an environment where we're no longer surprised. We've been talking about this for 5 decades or more. That's my frustration. It's a question, hopefully one or the other of you can take a stab at answering.
I think you would find articles of 40 or 50 years ago would also say the same thing about potentially a different subject, right? Governments are not good at long-term planning. We all know that. That isn't going to change. And part of the problem in things like healthcare and when you're projecting out in the future, that the impact of decisions made today, first of all, aren't felt tomorrow. They're felt many, many, many years down the road. And they're not felt all at once either. So when you think about the increasing age of our population and the increase in the proportion of our older population, it's a little bit incremental each year. There isn't this crashing wave that's coming over us all at once. It's a bit by a bit by a bit by a bit by a bit. And so that has added to the challenge as well, is that it would almost be better if there was the crash, because we had a crash called COVID. So we know, we found a vaccine was brought from, we're thinking about it, we've been tinkering with this for 10 years, to approval within an 11-month window because the world shut down, right? Well, that's not how it's happening with our aging population, and I think that is a challenge. And at the end of the day, I keep circling back, we are the government. We have not come to grips with the costs that we are going to have to pay. So, it's no surprise that we've got 2 phenomenon. We need more people to care for older people, phenomenon number 1, and we have to pay them a lot more, phenomenon number 2. If only one of those things were true, it would be bad enough. They're both true. And we haven't come to grips with that. The labor shortage is in the low-skilled, low-paid wage categories, not in the higher wage categories. The law of economics, of course, you're talking to an economist, it's irrefutable, right? We are going to have to pay a lot more. Pay enough, you will get the people. I was in Kitimat recently, so I did a northern tour. Everybody's all about, we can't get the staff and we can't find the housing. I said, maybe someone can explain to me how LNG Canada managed to recruit and house 5,000 people in Kitimat and we can't find a care aide. Well, they pay. That's different, right? Whether you think you can or you think you can't, you're right. So we need to come to grips with that. And governments will not have that conversation with its people. We will not come to grips with, we talk about this housing issue, and I was just talking to some media about it, seniors housing, seniors homeless. The fact of the matter is, the majority of seniors in British Columbia don't have a housing problem. In fact, they have a housing benefit. But the ones who don't own have terrible, terrible troubles. But because we won't talk about the houses that people have, we're treating low-income people. We don't do any asset testing. So what does that mean? That means that the woman who's making $29,000 a year on her pension incomes, living over in her $2 million house she bought for $40,000 60 years ago, is treated the same as the woman who's living in her $1,800 a month studio apartment in the West End, because we don't have the I've got to think of a better word here, the bravery, you know what I was thinking of, to have the conversation with our citizens about how are we going to pay for this? It's going to cost a lot more money. And yes, we need immigration, but immigration can't be code for cheap labor.
I'd just like to add with respect to cancer, I was working at Statistics Canada. We did the cancer projections starting in 1986, and Gloria, you were in various articles and books even, probably before I even started on that. I think the issue with the cancer care is there was a very good study, which I was co-investigator on, done in around 2008, that looked at exactly the problem that is now, and the basic results were never really acted on because a number of provincial deputy ministers of health said it's our responsibility and we can't take a national approach to looking at how to get the cancer specialists they need, because there's not that many. There's a few hundred sometimes. Yep. And the training for radiation technologists was all done in Ontario for the Atlantic provinces, but Ontario didn't want to take that into their supply considerations or demand. And so there's a lot of issues around that as well. This has been well known. I mean, I've been in government and there's been tons of reports. So why isn't government acting?
Territorial.
Yeah.
Hi, thank you, everyone. I guess listening to you, I'm just wondering, so then what's the answer? What are your priority areas or strategies forward? I mean, putting on my other hat, I helped develop the seniors housing inventory for the downtown east side and the Chinatown community. And the figures are just stark. You can't deny them. There's 13,000 affordable housing units. 23%, that's less than a quarter, are for seniors. So we know that there are 7,200 seniors living there. There are 3,000 units. 4,000 of them are on the streets, in shelters, or in inappropriate housing, which means SROs. We have a 90-year-old climbing up SRO stairs. The other great finding is the big gap that lies between seniors housing, which what they call independent seniors housing, and then your long-term care homes, which is average 85, 86 years old that you get into long-term care. So you have a 30-year gap where you're assuming that seniors are perfectly able to fend for themselves in independent housing. So there is a huge gap in terms of supportive care that actually integrates independent towards long-term care that is unprovided for at the moment. So I guess just narrowing the focus into two areas, just in terms of volume of affordable housing and integrated care and housing, what are your thoughts on the way forward? Because the figures are just going to grow if nothing is done.
I certainly don't envy policymakers and decision makers. There's a number of things that I think I can take from that comment. First is there's an intersectionality of things happening here. It's not just a population that's aging. There's a lot of things that are intersecting to lead to I would probably suggest places of crisis. Climate injustice, the housing situation. We know that we're starting to see the voices of people that have been historically oppressed show up. And so there's not only a number of priorities that need to be addressed, but I would suggest there's not a one-size-fits-all solution as well. Because of the different populations that we're working with, because of the different life experiences people are working with, and because of the geographical nuances of our province, and because of, I would probably suggest, entity ego. We're not able to kind of get to a place where we're able to address things before they happen. And Dr. Matthews, this kind of goes to your comment earlier too. Why are we surprised? Why are we surprised that the environment is being so impacted the way it is? We've known about this for ages. It's now that we're hitting crisis that we're trying to be reactive and responsive to a place where, to be quite frankly, this intersectionalities have heightened to put society in a bit of a crisis. So there's got to be a removal of entity ego. There's got to be a recognition that we have to look at where people are at in their ability to access programs and services. And I think we need to also look at being able to amplify voices where things don't work.
I think that part of the solution, certainly around this housing and this continuum, is about the money issue. So I go back to the people with money, and for the most part, they sort it out. It is the people who don't have the money, or they have some money but they don't have the sophistication to figure out how to sort it out. And what is interesting is, I found it interesting that Singapore's approach was to have the state build and own the infrastructure and have effectively the private sector operate it, which in fact we sort of want to flip that around in BC and have the public sector operate it and the private sector build it. I was intrigued by that. But when we look at this continuum of housing, as I say, if you live in Vancouver in a single family home and you're 85 years old, you can afford, when you sell that home, to go and buy your Sunrise assisted living or any of the upscale places, and you're going to be able to afford that. It's the people who can't. We don't have a good system for flowing it to them. The other thing is, governments have not, we haven't sorted out the incentives. We should be incentivizing us, to spend our money. How would we incentivize that? We'd have inheritance tax. If I've heard it once, I've heard it 100 times. The house is, this is what I'm going to leave for my kids. Okay, here's the way it works. Somebody pays. There's no free ride here. There's the old, everyone wants to go to heaven, no one wants to die. Your kids are going to pay one way or every higher taxes, it's like property tax deferral. Oh, well, my kids say I shouldn't defer it because, it'll be a debt. Okay, you realize you have to pay your property tax one way or another, right? It's either coming out of your bank account today or out of the sale of your house when you're dead. But the difference is when it comes out of the kids are going to get the house, and they don't want the debt against the house. So that's another part of the problem. That government, we haven't aligned our incentives, and I could go on and on, probably already have, about how we've misaligned all of the financial incentives. The private sector is not the enemy here. The natural discipline of the marketplace has something to be said for it. We just don't use it the right way. The public sector does not leverage the benefits of the private sector model in any way, shape, or form. And part of it is because the normal marketplace is between the consumer and the seller. Government's the middleman here, and that presents a challenge and corrupts it, for want of a better term. But I think, this issue around aligning the financial incentives, and if we did that, it wouldn't solve all the problems, but it would reduce some of the pressures we're seeing. And I'll just give you one example. Publicly funded long-term care in British Columbia takes 80% of your income, but stops at $3,800 a month. The most you will pay in a publicly funded long-term care home in British Columbia right now, and it goes up every year by CPI, is $3,800 a month. If I go to Sunrise down on Oak and whatever it is, 49th, I'm not even getting my basic hospitality services for $3,800 a month. We have misaligned those incentives because everybody's entitled to the $3,800 a month long-term care bed. No matter how much money you have, you can get that bed. And if we said, actually, no, we're going to keep taking 80% of your income until you've paid the market rate. Now it's going to cost me $8,000 a month to be in that long-term care home. I might make a different choice.
I'd just like to add, just very quickly, when we were doing our study of the housing in Langley, first of all, it's there, everybody knows it's there, but it's invisible. And because they're low income, because the tenants are low income, they don't get out much, they don't have their vision care, they don't have their mobility, they need their depends, and they can't afford to buy depends. But there's two acts. One is the Residential Tenancy Act, and the other, I think, is Assisted Living something. And there's quite a gap in there, and that is where there was a lot of problems in trying to house people that could be somewhat independent with supports, but weren't quite where they needed to be in terms of assisted living. Because once you're in assisted living, there's a lot of regulations, and you have to have doors locked and things like that, and you can't have guests necessarily. And it's sometimes the guests that are as much the problem as the residents or the tenants. I have to keep, they're not. Anyways, so that was one issue, and we can talk more about that later, but thank you.
Great, thank you. I'm so pleased that the three of you agreed to come and answered my email. The terrific panel. I'm sure we could speak on this issue for a long, long time, but we're going to have to cut it here. And on behalf of everyone, we want to thank you